Welcome to day one of the 16th Annual Hybrid Sickle Cell Disease Educational Summit. We are excited to begin our next session. We have two outstanding moderators with us today who bring a wealth of experience and dedication to the sickle cell community. First, let me introduce Dr. Wanda Witten-Sherney. Dr. Sherney is the CEO and Medical Director of the Sickle Cell Disease Association of America, Michigan chapter, and has dedicated over 30 years to the care of individuals living with sickle cell disease. A proud alumna of Detroit Public Schools and the University of Michigan, she is widely recognized for her remarkable work in patient engagement and education. Dr. Sherney has also served on the NIH's Advisory Committee and, in her free time, enjoys traveling and dancing. Joining Dr. Sherney is Kevin Wake, president of the Uriel E. Owens Sickle Cell Disease Association of the Midwest. Kevin earned his degree from the University of Kansas and a master's degree from Walden University. With a background in pharmaceutical sales and management, he holds a community health worker certification and currently serves as the chairman of the Patient and Family Advisory Council at University Health in Kansas City. His leadership and passion for advocacy continue to make a profound impact on the sickle cell community. Together, Dr. Sherney and Mr. Kevin Wake will guide us through today's important discussion. Now let's get started and dive into this insightful session. Welcome to the 16th Annual Hybrid Sickle Cell Disease Educational Summit, Unpacking Sickle Cell, one warrior at a time.
So Kevin and I are laughing up here because we had no idea about these introductory video things, and now we're both famous and we will be signing autographs at the end of the session. But what I really want to know is who is excited about what is going on in the sickle cell community now? Anybody in here excited about it? Because I am excited about it, okay? I do want to pause for a minute because I love Dominique. She didn't want to say how old I am. I'm 67 years old and I was born on World Sickle Cell Day, Juneteenth, so I know I have a purpose and I'm trying hard to fulfill that purpose. But I got introduced initially as Dr. Wanda Sherney, and I always want to make sure that Witten comes out. Because if any of you have ever heard me speak before, I always talk about ancestors, and how we are standing on the shoulders of our ancestors. And at our walk this year, at every walk, well, this year it was walking into a brighter future. So this is like the ideal time to talk about that, right? Because I feel like we really are walking into a brighter future. But I think one of the things that we do at our walk is that we pour libations for fallen warriors, and I think that it would be good. And when I talk about ancestors, I even talk about the ancestors who survived the Middle Passage, and thinking if you were on that ship and you actually were living with sickle cell disease and having a crisis at that time, what that must have been like, so I would like to just take a moment to have a moment of silence for fallen warriors, or to think about an ancestor that has been really important to you and to thank that ancestor for what they did. We'll just take a moment for that. Thank you. Now, I think Attorney Crump took away some of the things I need to say, and I think Captain Wong did too, but let me just say a few things and then I'll turn it over to Kevin. I think that with these treatments that are becoming available, there are a lot of important conversations that need to be had, and there are a lot of really important decisions that need to be made, right? And I'm going to tell you the truth. When the FDA approval for gene therapy came out for those two medications, I got some calls that asked me to express my opinion, right? And I decided I didn't want to comment because I don't know the answer. And I know that because I travel around the country and speak to a lot of warriors, a lot of people look up to me, and might want to do what I think they should do. And I have no idea what they should do because I have so many concerns about gene therapy, but I also have so many concerns about sickle cell disease, and so I think the best thing, and I think if you're trying to make that decision for yourself about either a medication or gene therapy, that's much easier than if you're trying to make it for your child, right? And how you feel if you get a negative outcome from that decision that you made. And that takes us back to the whole education situation, right? And, I just have to say that my great-great-grandfather was a former slave, bought a farm by marking the letter X because he could neither read nor write. And he had daughters, and the neighboring farmer also had daughters. And he said one day to them, "Are you going to make sure your daughters get educated?" And the neighboring farmer said, "I can't afford to feed my daughters, much less educate them." And my great-great-grandfather, Hugh Carr, said, "My daughters may not eat, but they will be educated." So in this whole education thing, because in terms of getting access, if we have medications, they don't do any good if the warriors are afraid to take them or don't feel comfortable, because one thing I know about warriors is they're strong and they're resourceful and they're caring, but they're also skeptical, and for good reason. So we need to be able to educate them about all of these things so that they can make, the key word I think is informed decisions, right? And I feel like when I talk to parents, what I tell them is that learn as much as you can about the decision that you're trying to make, and then pray about it, and then make the decision. And then whatever decision you make is the right decision. Even if you have a negative outcome, it was the right decision, because all you can do is what you can do when you're really trying to do the best for your family. Now I have to check my notes for 1 second and make sure I say everything that I want to say. And I think one of the most important things is that, for all that time, all we had was blood transfusion and narcotics. And I had a mother come up to me one time and tell me, "You made my child dependent on narcotics." And I said, "Yeah, I did, but I couldn't let him suffer in pain, and that's all I had." Now we have more than that, okay? And now the standard of care for individuals living with sickle cell disease should not be opioids and IV fluids. That should not be the standard of care. I'm not saying take away pain medication, because it's a painful disease and you need pain medication, but we need to also do other things. And we really need to have a multidisciplinary approach. And I think that learning about all of these treatments and even upcoming treatments is so important. And Dr. Raleigh, thank you so much for inviting me to be a part of this important thing. Now, the last thing I have to say is about access. And again, in Michigan, when Endari came out, Medicaid said you had to fail hydroxyurea to get on Endari, step therapy. And we said, wait a minute, a lot of people won't even take hydroxyurea. So what are you saying? If you won't take it, that's like saying, oh, we're going to force you to take hydroxyurea because it's cheaper. No, so we got that overturned in Michigan. And also I got an email from Captain Wong, and we're having a listening session in Michigan. So I'm really happy about that. So we got to get access, and the access also has to be to competent health care, because if you don't have a doctor who will prescribe the medication or talk to you about, or even mention the medication to you, how are you going to be able to take it? So I think that's important. Now, everybody who's going to speak today has a time limit, right? Now, I've been moderator before. I remember one time when I had to go up to the microphone and almost wrestle it away from the person. I don't want to do that again, okay? So I want everybody who's speaking to pay attention to their time, everybody except Kevin, okay? It's on you, Kevin.
Dr. Trini, thank you. I'm going to be like you when I grow up. So you did all this off of notes. I had to write down my little speech. So I apologize, but I'm not nearly as good as you. So, but thank you. Thank you for your comments, your thoughts. I think that really summarizes a lot of some of the things I was going to say. Um, but I also want to welcome everybody that's in the room, as well as all those joining virtually to the 16th Annual Educational Summit. It's an honor to be standing before you as a warrior and also a representative of a community-based organization. Today, we embark on a journey that is both personal to me, but also one that's critically important. One that weaves together the lives and lived experiences of warriors and those who battle sickle cell disease with groundbreaking advancements and treatments that are here, but also on the horizon. I'm thankful to be moderating today with you, Dr. Sherney. And I'm really happy to be part of Industry Day. That was a crucial part of my background. As a warrior, my perspectives have been shaped by over 56 years of navigating the complexities of this condition. Sickle cell disease is not just a diagnosis, it's a daily challenge that tests my strength, my resilience, and some days even my hope. Each day brings its own sets of battles, but it also brings, I think, opportunities for progress, change, and growth. And it's in that spirit that we approach all of the topics that we're going to talk about this week at the Educational Summit, and today especially, while we explore the advances that are before us. I really love the theme for this summit, unpacking sickle cell, one warrior at a time. And I really think that reflects what our common mission is. Each warrior's story is unique, and every experience sheds light on the many different facets of this condition. But by sharing our stories, our struggles, and even our successes, we can paint a fuller picture of what it means to live with sickle cell and then advocate for the solutions that matter most to all of us. Before I start though, I really can't help it but to reflect on the past and compare that to where we are today in the management of sickle cell disease. I'm old. I've lived through the days when sickle cell disease was primarily managed by daily penicillin, folic acid, and pain medicines. And then when it got really bad, maybe they throw in a blood transfusion here and there. But today, however, through awareness, advocacy efforts, organizations like Cayenne Wellness, and the work of industry, we've seen a dynamic shift in the landscape of therapies. Sickle cell disease is more than a diagnosis that comes with an early mortality rate. It's a more manageable condition today, where we have warriors living much longer and more productive lives. And we're actually going to celebrate many of those warriors later on this week, so I'm really happy about that. Today, we'll explore both FDA-approved as well as emerging therapies that hold the promise of transforming the lives of those affected by sickle cell. The strides that we've made in the industry are nothing short of remarkable. From pioneering treatments that have already been approved by the FDA to the innovative therapies that are yet to come, the landscape of sickle cell is truly evolving. Our goal today is to really understand these advancements and how they align with the real needs of our community. And I hope that we all leave here today more empowered with knowledge and understanding of what is available to us. But I have to say that even with these advances, there's still a lot of work to be done. Treatments and therapies are just part of the equation. I know that the current treatments may not be right for everybody, but we also have to make sure that these are accessible treatments in an equitable way for everybody. Many of our community is underserved and often overlooked in our healthcare system. And it's our responsibility as individuals, warriors, caregivers, advocates, organizations, and even industry that we bridge that gap. We must work together to ensure that every person affected by sickle cell can explore these new treatments and therapies, regardless of where they live, what zip code they are in, what their economic background is, and what their status is. Every day is a battle, but with new therapies, we are closer more than ever to changing the course of this disease. Today, we will further connect medical innovation and the community so that no one is left behind. So let's dive deep into these therapies, shedding light on what is currently available and what lies ahead. Our aim is to make these advancements more understandable, more accessible, and more relatable to everyone here so that the community can go out, make informed decisions, and advocate for the care that they deserve. So in closing, let me just say that while the path forward, it isn't always easy, but I do truly think it's full of hope. I encourage all of us today to listen, learn, and ask questions. There are no stupid questions, but we need to understand everything today while we're here and have that opportunity. The advances that we talk about today will represent more than just scientific progress. They represent a new chapter in the fight against sickle cell. A chapter where we as a community are more connected, more informed, and more empowered. So again, thank you for letting me talk. Thank you for letting me help moderate this with Dr. Sherney. Let me get off my soapbox and let's get started. So first, we're going to explore the 5 different FDA-approved modifying therapies. And so the first therapy that we're going to discuss today is hydroxyurea. And so would Dr. Powers Hayes join us on stage to talk about hydroxyurea?
Hey everyone, I'm actually virtual joining from Cincinnati, Ohio. Can you hear me or see me?
We can, but just give us one moment, Dr. Hayes, because there is a intro video. One moment.
I have an intro video?
Yes.
All right, let's see it.
Let's play it.
Okay.
Thanks.
Welcome to the Cayenne Wellness Center's annual Sickle Cell Disease Educational Summit. This next session, 5 FDA-approved modifying therapies, will highlight key treatments that are transforming sickle cell care. Our first speaker, Dr. Alexandra Power-Hayes, a pediatric hematologist at Cincinnati Children's Hospital, will discuss hydroxyurea, a foundational therapy for sickle cell treatment. Next, Dr. Charles W. Stark, Senior VP of Medical Affairs at Emmaus, will cover L-glutamine, which helps reduce complications in sickle cell patients. Following him, Dr. Alexandra Spence, West Coast Field Medical Director for Sickle Cell Disease at Pfizer, will speak on voxelotor, a therapy that improves hemoglobin levels. Then, Janice Nelson, Program Director at UConn Health's New England Sickle Cell Institute, will present on crizanlizumab, a treatment aimed at reducing pain crises. Finally, Dr. Melissa Anderson from Terumo Blood and Cell Technologies will explain red blood cell exchange, used to manage severe complications in sickle cell patients. After the session, Brianna Smith, an aspiring translational scientist, will introduce our summit survey. Let's get started with 5 FDA-approved modifying therapies and unpacking sickle cell, one warrior at a time.
That's very
You
cool.
are
Do you want me to
up.
share my screen?
Yes, ma'am. Please do so.
All right. Everyone see my screen? See me okay? Hear me okay?
Yes, ma'am.
Okay, wonderful. Well, hello, good afternoon, everyone, the Cayenne Wellness Group. Nice to virtually meet all of the sickle cell warriors and allies out there. As that very cool video mentioned, I'm a pediatric hematologist at Cincinnati Children's Hospital. So I'm joining you virtually today because I've been seeing patients in clinic all day and ran over to my office. But I'm very happy to talk to you about hydroxyurea. I'm going to speak a little quickly because it's a short amount of time to get through a lot of very important information about one of the medications we know the most about in its ability to help many patients with sickle cell disease. If anyone out there is on Twitter, please connect with me. I love following sickle cell advocates and cheering warriors on. Slide. Okay, I don't need to tell this group, but we know that untreated sickle cell anemia is more than just pain, and it causes both overt, meaning obvious, and silent damage throughout the body and throughout life. I'll go quickly through this, but we know it has the potential to affect the brain, the eyes, the heart, the lungs, the kidneys, the liver, the spleen, of course, the bone marrow, the reproductive organs, the extremities, and ultimately leads to a potentially a shortened life expectancy, and certainly can lead to a decreased quality of life. And so while we hope these complications don't happen for every single patient, we know that allowing sickle cell disease to take over is not the best approach. We want the patient, we want you as a human, not as a patient even, to shine, with sickle cell being as minimal of the boss of your life as possible. And focusing just on pain sometimes misses a lot of other complications that really have a large impact on patients' lives. I don't need to tell this group, but we know that a healthy red blood cell needs to be round and flexible to squeeze through the tiny blood vessels through the body. And we know that sickled cells get stuck, right? They cause both blockage or traffic jams, as well as they're prone to break. They're almost like twigs or pencils that are easily snapped. And as many of you know, these aren't just cartoons, but this is actually what blood looks like under the microscope for patients with sickle cell anemia versus without. But did you know that the blood in babies with sickle cell disease, even hemoglobin SS, doesn't sickle when they are newborns? And this is because all humans are born primarily producing a type of hemoglobin called fetal hemoglobin. Okay, so fetal hemoglobin, even in someone with hemoglobin SS disease, doesn't allow the sickled hemoglobin to change the shape of the red blood cell. But after a few months of life, even by 6 months of age, the fetal hemoglobin is replaced by whatever the adult type of hemoglobin someone is going to make. So if you have sickle cell trait, your fetal hemoglobin is replaced by some hemoglobin A and some hemoglobin S. If you have hemoglobin SS, that fetal hemoglobin is mostly replaced by hemoglobin S, and that sickles and that changes the shape of the red blood cells. One of the biggest modifiers of how severe someone's disease is actually what your natural production of fetal hemoglobin is. So two people with hemoglobin SS, so the same underlying mutation, we know everybody is an individual, and some might have significant pain and some might have quite minimal complications. And one of those major differences between those two people is their natural production of fetal hemoglobin. We actually know that the mechanism, the machinery, if you will, inside the bone marrow for still making fetal hemoglobin remains. So I think there was a session earlier on gene therapy where you probably did hear a bit about fetal hemoglobin. But hydroxyurea actually works by going back to the bone marrow, kind of actually slowing down the production of cells in the factory. And with that, it actually turns back on that machinery that produced that protective fetal hemoglobin when we are infants. And this works particularly well in people with the more severe sickle cell genotype actually have a better fetal hemoglobin response. So those with hemoglobin SS and hemoglobin S beta 0 actually get a very robust fetal hemoglobin response. And with the right dose of hydroxyurea over a few months, you can actually stimulate your body to make an increased amount of fetal hemoglobin that protects every single red blood cell. So this is a real patient who came to me from another center. She's a teenage girl. She has many complications of sickle cell disease and hemoglobin SS. And this is a picture of her blood smear in March. And then I saw her just in August. And you can see, like I said, these weren't just cartoons. These are actually the shape of red blood cells. She is very adherent to her hydroxyurea, not out of her own will, but because her parents are doing everything that they can to kind of help walk back some of the complications that she's been having. And so you can see her red blood cells, actually, she's still hemoglobin SS, right? So she hasn't undergone gene therapy, but her body still knows how to make fetal hemoglobin. And she's about 25% fetal hemoglobin. And with 25% fetal hemoglobin, she is able to have round, healthy red blood cells. I'm not saying all of our sickle cell complications are gone, but she is having significantly less pain. And her biggest concern was actually the yellowing in her eyes, her icterus, her jaundice, and that's gone down a lot. So she feels a lot more confident going into high school with slightly less yellowing out of her eyes. Okay, so I'm not going to go through this too much because I'm not even sure of my time. I'm sure I'll get flagged. But in studies where we have looked at patients with sickle cell disease in adults or children, and we've compared hydroxyurea to a sugar pill, we know that hydroxyurea decreases pain, decreases transfusions, decreases acute chest syndrome or severe pneumonia. And in follow-up studies, patients on hydroxyurea over 9 years had a 40% decrease in mortality. So this is why when you go to hopefully your hematologist, hopefully they are continuing to talk about hydroxyurea, at least talking about how it's worth trying. I'm not saying that it is a magic pill. It is not an overhaul for everything, and it's still a pill that needs to be taken every day or many times a week. But for those with sickle cell anemia, more severe genotypes, hemoglobin SS and hemoglobin S beta 0, we have so much data that it is certainly worth a try. Now, if you say, Dr. Powerhays, if this is so great, why are so many people with sickle cell anemia not on hydroxyurea? I have a few answers for you, and these are based off of studies where they've surveyed physicians and they surveyed patients. And I'll walk through them, and then if we have time at the end, maybe we have some time to do a little bit of Q&A, I think. But so provider-related barriers. I think it is not fair for any sickle cell warrior to be seeing a provider who maybe is endorsing some of these barriers, right? I think you owe it to yourself to be seeing somebody who knows enough about hydroxyurea to at least have these conversations with you. So there are provider-related barriers on providers not even talking to their patients about hydroxyurea. So and these are provider-reported barriers, right? So inadequate knowledge of hydroxyurea. I will say, all of the warriors out there, you deserve better than being seen by a provider who does not feel like they know enough about hydroxyurea. Or similarly, a lack of comfort in prescribing it, or concern about side effects. You deserve a provider who's willing to talk with you directly about potential side effects and work with you or hear you and hear your concerns, not one who themselves just doesn't know and hasn't educated themselves. So we know a lot of warriors see primary care doctors because there's a shortage of adult hematologists. And, that goes back to the whole access issue and giving yourself the best. Doubts about effectiveness are certainly out there. We know that the dose matters. And if you think about the mechanism of hydroxyurea, you need to be on enough hydroxyurea that your body is making fetal hemoglobin. So some people can't tolerate it, and that's fair. You've at least given it a go. But, if you just start on a low dose and your doctor doesn't feel comfortable dosing it correctly, of course, you're not going to gain the benefits because you haven't gotten the adequate dose. Doubts about patient adherence are widely reported by providers, and I think that is completely unacceptable and not fair. If your patient tells you they don't want to take a medicine, that is one thing, and that's acceptable. But to already in your head decide, oh, they're not going to take it, is not giving your patient the benefit of the doubt. And I have this conversation with medical trainees and emergency room physicians all the time, that you don't get to prejudge your patient's adherence to your recommendations. And then the cost of hydroxyurea is reported, and I think that is, I don't really understand. If you have Medicaid, hydroxyurea should be covered. Maybe you have a high deductible But that shouldn't really be a limitation to prescribing it. Then, of course, there's patient-related barriers, and these kind of I tried to order to match on with the provider side. So patient-related barriers, patients report not knowing enough about the medication. So that's fair, which again goes back to you should have a doctor who knows about the medication. I'm happy all of you are in the room here, so we're educating yourself already, but you deserve a doctor who can at least have a conversation about hydroxyurea. Patients worried about side effects. This is a very real concern, and this could be a whole talk on itself, and I really do hope we'll have some time in the Q&A to talk about this. Tried it and it didn't work. That's valid. If you tried a medication and you really, gave it a shot and it didn't work for you, or you had side effects that were unmanageable, then at least you tried it, and that's fair, a fair barrier. I'm so glad that there are other medications out there that people can now try, but you've at least tried it. Forgetting to take your medicine, what patients report as well. And then not interested in taking another medication. And I think not interested in taking another medication or any medication. And I think if you're in the boat of not wanting to take any medication, I think you should give a little bit of pause and a little bit of self-reflection, because we know that the sickle cell is not going to stop as your body will continue to make those cells. And so really do some true introspection or conversation with your family, as Dr. Sherney mentioned, give it a little bit of prayer, whatever it is to you, on is it really worth not taking any medication to allow this disease to kind of still be the boss of someone's life, which is not the goal. And the last, I'm sure, of less than 30 seconds that I have, we have this question all the time: is hydroxyurea toxic? Like I said, this deserves a whole talk in itself, but I'm trying to get through in 10 minutes. When people think about is hydroxyurea toxic, I think we are talking about a few different aspects of what toxic means. Hydroxyurea started as a chemotherapy. It was not a very effective chemotherapy in the 1960s, but it was approved first to treat cancer, and sometimes it's still used. Like I said, it wasn't the best chemotherapy and was repurposed and is much better as a sickle cell treatment. But I think because it started as a treatment for cancer, people then interpret, well, does it then also cause cancer? So they've done large reviews of pooling all of the available published data. So it's called a Cochrane review, when you literally pull all the case reports and all of the publications and you put them together, and you then are able to look at a large swath, and there are no increased risks of cancer in people with sickle cell disease who've taken hydroxyurea even for decades. We unfortunately know that sickle cell disease itself can predispose you to certain types of cancers in the kidney, as well as leukemia, but there's no increased risk from hydroxyurea itself. There are fears of infertility. I think this is such an important topic to look at. As I mentioned, I'm a pediatric hematologist, so I'm often having this conversation with parents of young children who would hate to do anything to limit their potential to have grandbabies. Like, that's, once a family has gotten over the excitement of their own baby, what's next is they're thinking about grandbabies. And there's a lot of concerns on both sides of the aisle with this. What I say is that conceiving a child requires being healthy and happy enough to find a partner and to be fertile. And we know that hydroxyurea prevents strokes, prevents avascular necrosis, decreases the rates of priapism, and all these things that can actually also decrease your ability to conceive. And so this is a really one-on-one conversation with your doctor. And this is, I think, is why, to go back, you deserve a doctor you can have conversations like this. And then worries about darkened nails. Some people do get darkened nails with hydroxyurea. I think, again, that comes back to a conversation with you and your provider of if that is a reason to not continue the medication, or hair loss. And so I'm not minimizing these. I just put them out there and say, you deserve it to yourself to really think about if you should be on a medication that can help you be the boss of this disease.
Dr. Haig.
Again, I don't know if that was 10 minutes, but thank you all for your time.
Thank you.
And I was getting messages. 1 minute remaining, sorry.
Okay. Okay, great. We will field questions at the end for all the different disease modifying therapies. So Thank you again for your presentation, hydroxyurea. Next, we have L-glutamine.
So this is Dr. Charlie Stark.
Mhm.
Nice to see you. And you have 10 minutes.
10 minutes it is. Dr. Power
And
Hayes
you're
did an
here, so I
incredible
can stop
job.
you.
So thank you very much for inviting us here. And I've been with this company for about, well, we've been working on this project for 20 years, which is developing a therapy for warriors from the ground up. This was developed exactly for warriors, and we became the second therapy ever approved by the US FDA in the United States. And so I'm going to give you a little bit about Endari or L-glutamine. And I work for the company, so that's what the disclosure is. And we're going to talk about how it works and about the clinical trial data, and then finally about safety. So a little quiz to begin with. What is Endari? It is an amino acid. So we'll just talk a little bit about amino acids later. And what did the phase 3 study, the pivotal study, show? And how is it taken? And finally, can it be taken with hydroxyurea, the very agent that you heard about prior to my presentation? And so what is Endari and what is an amino acid? We need about 20 amino acids to produce all the proteins in our body, all the structure, hair, teeth, all the great things that we have that we sort of enjoy. And 10 of them you must eat. You must eat them. That means you can't make them yourself. The other 10 you can. You can make it yourself. But unfortunately, sometimes you can't make enough because your body's under tremendous amount of stress. For example, trauma, whole body burns, sickle cell. Okay, those are tremendously burdening cases where you need to take extra. So Endari is L-glutamine amino acid in pure crystalline form. And it's the most abundant amino acid in the human body. You can get it from food, as it's listed on there. And that the problem is you can't eat enough or make enough if your body's under way too much stress, and you need to get pharmacological amounts or medicinal type amounts. And that's where Endari becomes a prescription item. How does it work? Well, we've been asking that question for a long, long time. And it takes a long time and a lot of money to try to come up with that. And by the way, our office is right next door in a small office with, oh gosh, only about 5,000 square feet and 15 people. That's how small we are. And somehow or another, it's hard for us to find out how it all works. But basically, glutamine gets inside the red blood cells a lot. And that's the data that we showed when cell phones used to be the size of bricks, and all it did was make phone calls. And we showed that NADH, which it contributes to the manufacture of NADH. And I hear doctors say, "Oh my God, I had a PTSD moment," when you start showing that kind of stuff on the screen. Yeah, but it's one of the antioxidants we have in our body. There's some more in the red blood cell, but that's one of them. And we've shown that one of those actually increase by giving glutamine. And that NADH is actually low in warriors than they are in those folks who don't have sickle cell disease. And this was done in a Saudi Arabian population. So we can see here that NADH is low in general, and there's a lot of overlap there, but in general it's lower, and that giving 30 grams a day of L-glutamine actually increased or normalized the NADH antioxidant levels. And so we thought, well, that was a good NADH story, but the US FDA asked us to do a post-marketing study, and they asked us to do it on a biological marker, NADH, but we found out we couldn't do it. And it took us years to figure out that we couldn't do it. So we actually worked with a French group who looked for a biological marker on how L-glutamine might be working. And we think we have the answer for the US FDA. This is basically a P50 curve, which means it sort of measures how oxygen is being carried by the hemoglobin. So in this particular curve shows that in this at week 2, week 6, and at week 24 or 6 months, we show an improvement in the oxygen carrying capacity of hemoglobin. What does that mean? The hemoglobin is probably being more efficient in carrying oxygen for you. So that's another mechanism that we were able to see that's coming through, and we hope to do further studies into the future, because the NADH stuff just gives doctors a lot of problems. So in any case, what did the clinical trial actually show, the phase 3 trial? It showed that it decreases pain crises by 25%, hospital admissions by 33%. If you were hospitalized, you were in the hospital for a shorter period of time by 41%, and then 63% fewer people actually experienced acute chest syndrome. And that's a lot, because hydroxyurea already halved the acute chest syndrome to begin with, is an effective agent. Now, as far as safety is concerned, if you can see, the numbers are a little bit different because this combines 2 studies to look at safety, all those people who were exposed. And you'll see that this is a list of those where Endari is higher than the placebo and greater than 10%. So in this case, as you can see, there's about a 3% difference in constipation. And as you can see, the numbers are not that dramatically different. Although, let me point out the last 3 to you. Pain in extremity that was seen in the 5 to 12 years old, back pain that was seen in the 13 to 18, and chest pain not due to heart, not the heart, was seen across the age band. And we believe those truly can be the side effects of Endari. So if you see that, that is something you really do need to point out, because that could be the case. Now let's look at the serious adverse events. You'll notice that the placebo side is actually higher. So, as far as the serious adverse events are concerned, that's not really a worry. And then how many people stopped the study because they had a side effect? Well, not many. So as far as safety concerns, it is an amino acid. You do make it in your own body. You could eat it from food, but now you're taking lots of it. And can lots of it be a potential problem for some people? Rarely, but it can. But for the most part, it's not really a concern. And so what is it? It's a conditionally essential. That is, if you're under a lot of stress, you will need it. Orally administered, which makes it kind of easy, 5 years of age and older. And with or without hydroxyurea, you get the same effect, and it's for all genotypes. So HBsC, SC disease, for example, SD, SE. And finally, how do you take it? Well, it's in a packet, 5-gram packet. You rip it open and you throw it into a beverage or a food of your choice. Does it have to be cold? We used to say it has to be room temperature or cold. Nah, it could be warm. Just throw it in there and have it quickly. It'll work. Okay, and it's taken twice a day. Now the quiz one more time. What is Endari? It's an amino acid in its purest form. It is the natural substance your body naturally makes and you can get from food, but you need more of it. And the phase 3 study showed that there's decreases in acute pain episodes, hospitalizations, duration of hospitalizations, and acute chest syndrome. You also, how you take it? Well, easily mix it with the things that you normally would like to mix it with. And finally, yes, absolutely, you can take it with hydroxyurea. One will get the same amount of benefit. So basically, that's it. I think I'm under 10 minutes. All right, thank you very much.
So is the next medication virtually or is it in person?
Next, we have in person.
Oh, but next we're going to talk about crizanlizumab. I think it's going to be virtual because I don't see Dr. Nelson in the room, but it will be
Yes,
Dr.
it is virtual.
Okay,
And
so we're ready for Dr. Janice Nelson.
yeah, we have her slides up. Are you guys able to see her slides?
Yes.
All right. Dr. Nelson, take it away.
Good evening. Thank you guys for having me. So we'll get right to it. We're going to talk about Adakveo or crizanlizumab. Do I have control or you have control?
You have control, so you control it.
Display settings above.
Is right.
Almost. You're gonna have to reshare your screen so the people and the saints in the area can see. All right, there we go. Presentation mode.
If you go to the presentation mode, you could click the one at the bottom on the right that look like a projector.
Yeah, that's what I'm clicking and it's not doing anything.
Okay, go to resume slideshow. Right there.
Where the font tab is.
Yeah.
I think we're almost there. If not, tech team upstairs, please get ready to share her screen. And what we'll do is we'll ask you to give us the next slide, please. So tech team, please go ahead and stop sharing her screen and we will prepare to share. 1 second. You can go ahead and just gently introduce yourself. We'll
Sure.
about 1 more minute and then we'll pull up your slides for you.
All right, thank you so much. Again, good afternoon. I'm Dr. Janice Nelson. I'm a nurse practitioner and the program director at New England Sickle Cell Institute in Farmington, Connecticut, and I worked with Dr. Bari Andemariam. We have a program where we manage about 400 adults who have sickle cell disease, and I am very proud to be able to present this information on crizanlizumab. Okay, thank you so much. So, next slide. So crizanlizumab or Adakveo was approved in the United States in November in 2019. It is the first and only FDA-approved once-monthly treatment to reduce the frequency of VOCs or pain crises in sickle cell disease. It is given as an intravenous, meaning into the vein infusion. Adakveo is designed to reduce how often these painful crises happen. It was first developed by Reprixis Pharmaceuticals and acquired by Novartis in 2016. So how does crizanlizumab work with people with sickle cell disease? Crizanlizumab slows or stops red blood cells, white blood cells, and platelets from sticking to each other and inside the blood vessel walls. So people who take crizanlizumab may have fewer pain crises and spend less time in the hospital. So how does crizanlizumab work specifically? It's a P-selectin or a protein that is found on the surface of the endothelial cells that line the inner walls of blood vessels. During inflammation, P-selectin traps circulating white blood cells that and cause them to slow down and make them roll along the blood vessel wall to help with the immune response. But P-selectin is overproduced on the surface of endothelial cells and clot-forming platelets in individuals who have sickle cell disease. So along with white blood cells, sickle-shaped red blood cells also get trapped by P-selectin, causing them to become stuck within blood vessels. Adakveo contains a recombinant or lab-made antibody that binds P-selectin and prevents it from interacting with blood cells, including sickle-shaped red blood cells. So the treatment with Adakveo is expected to reduce the frequency of VOCs that occur when blood flow is obstructed by clusters of misshapen blood cells. So to put it very simply, think of crizanlizumab or your body as being a car. And the crizanlizumab is oil. And so the oil coats all of the components within the blood vessel so that it doesn't stick together, it slides easily. And so that way it reduces pain. So who can take crizanlizumab? People who are 16 years or older can take crizanlizumab. Providers are currently studying if it is safe to take it in a younger patient population. You can take crizanlizumab even if you're already taking hydroxyurea, which was explained to us in a previous talk. There are no contraindications for the use of Adakveo in sickle cell disease patients. So if you're a patient who's at home, who's managing pain, have a talk with your provider so you can determine if this would be a medication that you could use that can help decrease the frequency of pain that you're managing at home and or in the hospital or emergency department. So how do you take crizanlizumab? Again, it's an infusion. The medicine is put into a person's vein through an IV, which is a small tube. So the IV is placed into the vein with a small needle. The needle is removed, leaving just the tube there. And when the dose of crizamizumab is done, about 30 minutes afterwards, the IV is removed. So people get this medication once a month in either a doctor's office, an infusion center, an outpatient part of the hospital, depending on what their insurance is. So the typical dose is 5 milligrams per kilograms, and kilograms are determined based on your weight. So if you weigh 150 pounds, you want to divide that by 2.2, and then you'll figure out what your dose is. And so when you initially take this medicine, you have to do what's called a loading dose. So on day 1, which is week 0, you get 5 milligrams per kilogram IV. 2 weeks later, you will repeat that dose, and that's your loading dose. And therefore, after that time, you will get it every 4 weeks thereafter. So once the person starts on the medicine, after that first month, they just need to come back once a month to continue to get these monthly infusions. Does crizamizumab cause side effects? Most people who take crizamizumab do well and don't notice any side effects. But sometimes you need to slow down the IV to reduce mild symptoms. Sometimes you actually have to give some IV hydration or boluses, because we know that sickle cell disease is an inflammatory state. And so some people may have some mild dehydration. So if you bolus an individual prior to giving them the crizamizumab, you can decrease some of the side effects. Some possible side effects could be pain in various locations, headache, fever, chills, shivering, nausea, vomiting, diarrhea, tiredness, sweating, hives, itching, shortness of breath, or wheezing. If you experience any of these symptoms after you've had your infusion, please return back to your doctor's office or emergency department, because you may need some assistance in managing these symptoms. Women who are pregnant, planning to become pregnant, or breastfeeding should also talk to their provider before receiving a Dactyl, because we want to make sure that the baby is as healthy as possible. So, cost. The amount you pay, if anything, will depend on your insurance. So in the state of Connecticut, crizamizumab is on formulary, and so it's not anything that people who have Title 19 has to pay for. Private insurances may operate a little bit differently, but you can have that discussion with your provider. There are some programs that are available to help pay out-of-pocket costs if there should be any associated with it. But again, talk to your team so you will know what your options are when it comes to crizamizumab. If it's a parent who's providing this treatment for their child, talk to the child, let them talk to you so that you can relieve any fears, and so that everybody can be on the same page when you're ready to make a choice, because you want to feel good about whatever choices you're making for therapies when it comes to your children. So benefits of crizamizumab: it stops the blood cells from sticking together, and therefore it decreases VOCs. So it's a win-win. Thank you. And I'm sure I did that more quicker than 10 minutes, Dr. Sherney, trying to stay on focus.
You did, Dr. Nelson. Thank you very much. We're
You're
actually
welcome.
up. Great. Okay.
So next, we're going to do transfusion therapy.
Let's see if I can drive this thing before I get started, Joe.
Okay, so this is Dr. Melissa Anderson, and she's going to talk to us about transfusion therapy.
While my slides load, I'll just say good afternoon. I'm Melissa Anderson. I, by training, a physician pharmacist, jack of all trades, master of absolutely none. I do work for Terumo Blood and Cell Technologies. Unlike my predecessors this afternoon, instead of a pharmaceutical product, I'm going to be talking to you about a procedure, and that procedure being automated red blood cell exchange. I'm going to try to keep us on track and follow Ms. Nelson, but I'm from Kentucky, as the accent gives away, and we do not do many things quickly, but I'll see what I can do. They may show, they may not. I know them by heart. Well, while the slides are coming up, I'm going to be talking about automated red blood cell exchange transfusion. But as most of you on this room are well aware, there are multiple ways you can give a transfusion. First and foremost, you can get a simple red blood cell transfusion. And that is where you'll receive a predetermined number of red cell units without having any of your cells removed. Second type falls into a different category. There's exchange transfusions. And exchange transfusion can be manual or it can be automated. The first type mentioned was a manual exchange. And the manual exchange transfusion is it's done through a series of phlebotomy and followed by replacement. So you'll have whole blood removed, and then you're going to have red cells given. So there's going to be a period of removal of whole blood followed by replacement with red cell units. Here we go. Just trying to call my memory.
Can you guys see the screen? Give me 1 second. Like presentation.
It is nice to have notes to fall back on.
You want to use the clicker, don't you?
Sure.
I thought so. Dominique, if you can do me a favor and stop sharing your screen. Thank you so much. We like clickers. Hold, please.
Is there a direction to point? Left, right, center?
Left, right, any way you want to. Here we go.
Oh boy. Okay. Like I said, I did not mention the disclaimer. The disclaimer is that, again, I am employed by Terumo, and today I'm talking to you about automated red blood cell exchange, but I am not, obviously directing that as your therapy. That is something to be determined by you and your provider and your family. So automated red blood cell exchange, like I was mentioning earlier, there's multiple ways to skin a cat. So multiple ways to give a red blood cell transfusion. You can do the simple transfusion, just receive those predetermined number of units without having any of your red blood cells removed. You could do an exchange procedure, and that exchange procedure could be manual, which is originally that was the only way, it was the old school way of doing it. Serial phlebotomy. So you're going to have periods of whole blood removed, followed by replacement with those donor units. And now with technology, we have a machine, it's an apheresis device or an automated blood cell separator. And that machine, depending upon your vascular access, can efficiently, rapidly remove the patient's red blood cells. So removing those red blood cells with the hemoglobin S and replace them with the healthy donor units. And because you're able to do that, hopefully simultaneously, that is going to be an efficient process, a rapid process, going to reduce the amount of time needed per procedure. And when you are frequently having to go to the hospital, frequently going to your doctor, those minutes matter. We want to make those encounters as short and get you back out, get you into your life, get you home to your family. So this is a busy slide. But it's basically, I wish in medicine that any specialty could get along. These are 3 different governing bodies, and they each provide their own recommendation or guidance for how red blood cell exchange should be used when you're treating sickle cell disease. And the first, there's an American Society for Apheresis, and they provide guidance for both utilizing red cell exchange as a preventative. And with that preventative being prevention of primary stroke in pediatric patients who have that elevated transcranial Doppler pressure. And it's also for a preventative, if you've had that first stroke, you're going to have a prevention of a secondary stroke. So it's a secondary prevention. You'll see there that the ASFA guidelines, those are the 2019 listed. There was a 2023 release last year. The material has not made it through legal yet, so I had to stick with the 2019. I will tell you guys though, there was no update in the ASFA guidelines in 2023 in terms of the guidance for sickle cell disease, both in terms of using it preventatively or treatment. The other two bodies there, you've got American Society of Hematology and the National Heart, Lung, and Blood Institute. And these three bodies, again, they provide their guidance on how do you use red cell exchange to prevent complications and how do you use it to treat. So in treatment, it is used as a first line or that first therapy you're going to if you're experiencing a stroke or in severe acute chest. Again, because this is, red cell exchange allows you to remove and replace simultaneously. That should be, for that exchange procedure, for that transfusion, you're going to be doing that a little more efficiently, and those minutes matter. So you're going to, when you're going in for that transfusion, for that exchange procedure, it's going to be fewer minutes. And when you compare exchange transfusion, automated exchange transfusion versus the old school, the manual, it's about half. We have multiple studies because this procedure has been around for a while. So numerous studies showing that in patients receiving automated red blood cell exchange chronically, so that's how you're managing your disease, that procedure is about half. And when you can cut a procedure in half, that's substantial. Because again, every time you go in, we want to get you back out, get you home, get you back to your life, instead of seeing folks like me in an office or a hospital somewhere. So why would you use red cell exchange, or why do you utilize transfusion management? So when you are replacing those hemoglobin S red blood cells with hemoglobin A, or those healthy donor cells. And by doing that, you can reduce those vaso-occlusive crises. And vaso-occlusive crises, and that pathophysiology is kind of the foundation of many other complications. And we have numerous studies throughout the years demonstrating that if you're utilizing automated red cell exchange chronically as that modality to treat your disease, you're going to have fewer VOCs, so fewer vaso-occlusive crises, which, the fewer incidents over time, hopefully the reduced severity and the reduced accumulation of other complications. Speaking to acute chest, so one of the most severe complications that can follow that vaso-occlusion is acute chest. And utilizing chronic red cell exchange in the management of sickle cell disease, we were able to show that those patients had fewer incidents of acute chest, and then also when they were presenting, they were having a shortened course or shortened episode in terms of getting that under control, getting that patient back out to their family. So talking about stroke prevention, as I mentioned earlier, those three governing bodies all provided guidance on how you use red cell exchange to prevent and treat. In terms of prevention, for pediatric patients with that elevated transcranial Doppler, red cell exchange is used to prevent that first stroke. Once someone's had a first stroke, be that a kiddo, peds patient, or an adult, you can utilize red cell exchange to reduce the likelihood that they're going to have the secondary stroke. And all of those things matter. Reducing infarcts, reducing strokes is substantial. Everything you can reduce makes a difference in the quality of life for that patient. And we're able to show that with chronic red cell exchange, it's reduced primary in peds and then reduced secondary stroke in adults. So speaking to some specific populations, first mentioning pregnancy, you can utilize red cell exchange, automated red cell exchange in pregnancy. And there was a study demonstrating that in those patients, so in pregnant patients with sickle cell disease, you're having a reduced number of vaso-occlusive crises, and there are studies demonstrating reduction in maternal mortality. And there's worlds of work needs to be done there in the sickle cell community and African-American community in general, in terms of our maternal mortality numbers. What I didn't mention earlier, because I was trying to go off the top of my head. So red cell exchange, because we are removing and replacing at the same time, it's a isovolemic. So the volume you're removing is going to be the volume you're replacing. And then because you are removing and replacing, it's an iron neutral. because you're going to be removing those cells that would be breaking down. So you're going to be removing them. And, by keeping the iron neutrality there, you're going to have less exposure to iron in the acute period, less a chance for iron to accumulate over time. And less iron accumulation means less side effects that you're likely familiar with that are due specifically to too much iron in circulation. Alloimmunization. Now, this is something that's kind of counterintuitive. For those of you all that have received automated exchange, when you see those, it's a substantially more amount of red cell units that are utilized in that procedure compared to a simple transfusion. And when I've been working with Primo a couple of years now. I was thinking if you're getting more red cell units, more bags of blood every time, it would be a greater risk. What we were able to, what's been demonstrated over the years is that if you're on chronic red cell exchange and you're able to reduce the frequency that you're coming from your exchanges, extend that interval, over time, you're actually going to have a lower alloimmunization risk. So, and every time that you can reduce an antigen, making that, reduce the likelihood that finding blood, transfusible blood is a challenge is tremendous. Because I know for some patients that, as you're working your way from pediatric through adulthood, that becomes increasingly harder. So reducing alloimmunization risk, that is shown, even though per the procedure, you're getting more blood. So contraindications always have to follow what it can do with safety. So basically, anyone who could not receive a procedure, be it red cell exchange, there's white cell depletion, plasma exchange, there's a number of procedures that can be done on this machine. If a patient has experienced a serious adverse event with any other procedures, obviously there'd be a contraindication here. Any of the replacement fluids that would be utilized, and adverse events with red cell exchange are going to be those adverse event profile that you are familiar with in terms of transfusion in general. So transfusion related reaction, volume overload, you do list that, even though we're, again, stated that volume isovolemic, we do still list that. The feeling of lightheadedness or chills, fever while you're receiving the procedure, and all of those things can be managed or mitigated, by speaking up during the procedure, and having that voice while you're receiving. When we do not mention there, obviously those are contraindications. What are the bad things that can happen? And, unfortunately, with red cell exchange, one of the bad things that is just a challenge in access. And we're trying to do our part, individual states and across the nation, making sure for those of you that want to utilize red cell exchange, that's actually a possibility. And you guys grab me if you have any questions about red cell exchange or, how to access it. I'm happy to help anytime. Thanks for having me.
Thank you. So now we're going to have Brianna Smith come up and introduce the survey.
All right, good afternoon, everyone. My name is Brianna Smith, and I'm here to tell you a little bit about how you can all participate in community engaged research. And you can do that by taking our gene therapy survey. Before I get into what that is, I just want to tell you a little bit quickly about myself. So I recently graduated from Duke University in North Carolina this past May. And then, thank you. And then I moved from my hometown of Philadelphia all the way across country to Los Angeles to work at UCLA. And at UCLA, I work under the Clinical and Translational Science Institute. Specifically, I work on the Community Engage and Research Program team. And on that team, one of my largest jobs is doing community engaged sickle cell research. Ultimately, my career goals, I want to improve health outcomes in my community, the Black community, through research like this. So this survey has been one of my first opportunities to do that type of research. So as you can see on the screen, there is a QR code for the survey. Don't worry if you can't scan it now, it'll be on basically every slide, and the QR code is also in the center of all your tables. So this survey was developed through a partnership between 3 different entities. So first, Cayenne Wellness, as you all know and love, they put on this amazing summit, and they had a large hand in helping us to create this survey. Then we have the CTSI, this is where I come from, the Clinical and Translational Science Institute. And the Clinical Translational Science Institute is an NIH-funded research center composed of UCLA, Charles Drew, Cedars-Sinai, and Harbor-Lundquist. So the CTSI promotes the translation of research from the bench to bedside and community. And we partnered with the California Institute of Regenerative Medicine, called CIRM, and they promote the development of stem cell treatments to improve lives in California. So our main goals with this survey are, we want to understand the awareness and knowledge of new sickle cell therapies among sickle cell warriors and their families. We want to examine the challenges of accessing these therapies for sickle cell warriors. So ultimately, we hope to develop feasible, community-informed strategies for expanding the use of these new sickle cell disease therapies. So you may be asking yourself, why should I take this survey? So I just want to tell you some reasons that you should take this survey, and we would really appreciate it if you do participate in this research. So firstly, I cannot stress this enough, research is extremely important. Gene-modifying therapies, as many of you know, are just developing. They're still fairly new. Some of you may know a lot about them. Some of you may have never heard of them before. So while we know about how they work, what they do, little is known about the experiences of sickle cell warriors with these therapies. So this survey is a first step to understanding community knowledge, concerns, and hopes for these new treatments. Ultimately, we would like to develop more effective ways for sickle cell warriors, caregivers, their health providers, and researchers to discuss these new therapies. And we want to provide equitable access to these therapies for all patients. Also, we want to share your needs and concerns. This research can not only benefit you, but it could benefit your whole community. You taking this survey could benefit people that maybe can't take this survey or aren't sitting in this room right now. Getting this information, while it will benefit you, it'll also benefit the sickle cell community as a whole. And not only will it benefit those with sickle cell, it'll benefit healthcare professionals. Healthcare professionals like doctors, nurses, and more will have access to this information. So they will use this information to know how they can better care for you. So we need your help to educate others, and we first want to learn from you. Your voices are the most important in educating healthcare professionals and understanding more about how sickle cell warriors and their caregivers feel about these new therapies. Warriors and caregivers, your voice matters. Too often, the most important voices aren't reflected in research. Research can be kind of far from the people that it is supposed to be benefiting. That's why community engaged research is so important. We want to bring the people into the research, bring the community into the research. We want to make sure that the people who the research is supposed to benefit are there with us aiding in the research. So we can't make this change without you. So now that I've told you why you should take the survey, I'm going to just give you some details about it. So the survey is brief. It takes about 10 to 15 minutes, and it's a mixture of multiple choice and open-ended questions. You can complete the survey electronically by scanning the QR code, and you can also take it here at the summit on paper. So we have paper copies of the survey over at the UCLA Health table to my left, and then you can also get paper copies from the other CERT volunteers back there. And also, I'll be here every day of the summit. So if you want to ask me for a paper copy or learn more, want to take it, you can come up to me and ask. So we also want you to know that we do value your time, and you will be compensated for taking the survey. So everyone that participates and takes the survey will receive a $25 gift card via email. Should take about a week or so to come. So We want you to know you take this survey, we do care about your time, and we will make sure everyone is compensated. So the survey is confidential. Your identity and responses will be protected. So you can be as honest, as blunt as you want to be on the survey, and you don't have to worry about anything coming back on you or anything you said being exposed or put out there. When the data is reported, it will be reported in aggregate, which means as a group. So it'll be reported as what are the trends, what is the group saying, not what one specific person said or putting anyone's name out there. So you will be protected. There's also opportunities for future research. Each participant will have the opportunity to put their name down to participate in focus groups to help us further aid in this research. So if you want to keep putting your voice out there, you want to become more active in this space, you will have the opportunity to do that. At the end of the survey, there is a place to put your email and you can sign up for a focus group, because while surveys can be helpful, they also can be limiting. So focus groups can be a way for you to really share your story, get more in detail, and really help us to continue this work. So we plan to report these findings. The data will be analyzed with community input and compiled into a report. The report will be shared through Cayenne and through UCLA through newsletters, listservs, and websites. So we want to make sure that these findings are not only staying within the research community, but they're available to the sickle cell community as a whole. So if you have any more questions or you want more information, like I said, I'll be here every day. So you can come up to me and ask. And also my email is up here, and on the survey, there's also an email for questions. You can ask the UCLA Health Table or any of the other CERT volunteers. Thank you so much for your time and consideration. I really hope you do take the survey and help us on this goal of improving health outcomes for sickle cell warriors. Thank you.
Brianna. It is so inspiring to see a young woman with such clear career goals that you're already well on your way to, and to have chosen that as what you want to do with your life. I just want to really thank you for that.
Thank you so much. That's so sweet. Thank you.
So, boss lady, how are we going to handle the Q&A? Are we going to bring people up here, or how are we going to?
So we have maybe about 5 minutes for questions. And so we could take a question in the audience, and then we could take a question from virtual.
Okay, so we're going to go back and forth.
Yes, and we do have a mic.
And we only have 5 minutes.
So that we can share.
Okay, but I want to make one quick comment, and that is that I've heard hemoglobin SS being described as the most severe form of sickle cell disease during these presentations. And I kind of have a reputation for describing sickle cell warriors as snowflakes, and everyone is different. And for me, the most severe type of sickle cell disease is when you're sick. And there are people with SC that have a lot of difficulty, and I know some people with SS that don't have much, but statistically, it makes sense in terms of overall prognosis, but that's important for the entire community. For the individual, it's important to know that it's 100% for you how you do, and we want you to do well. Okay, I'm gonna take too much of the 5 minutes, so who else has a question? Anybody in the audience? Okay, Cole. I always call you Cole instead of your first name. I don't know why I do that.
That's fine. My question is
say who you are, please.
Okay, so I am Elle Cole. I am a caregiver in the sickle cell community, and I have a question regarding Adakveo. I know that it is approved for 16 and up, but I know that many hospitals have been having trouble getting the medication. So for people who are struggling, what is the advice? How do they go about making sure that their facility does have a steady stream of Adakveo?
Okay, so clearly that's a question for Dr. Nelson.
So if there's a issue with the pharmacy needs to work with Novartis in order to help their procurement. We haven't had that experience. The experience that we've had with acquiring Adakveo has been with people's insurance. So depending on your insurance, private insurance, wants people to go to a different infusion center. So they may do what's called white bagging, but we haven't had an issue with our pharmacy being able to have the medication on the shelf. So if it's an individual entity that's having a problem getting the medication on the shelf, I would suggest that they reach out to Novartis to help to figure out what the procurement issue is with getting access to the medication, because it is available. We haven't had any issues being able to get access to the medication.
Thank you. That's
You're,
great.
you're welcome.
Dominique,
All right.
Justin,
Dominique,
can I add a little bit to that? So the European Medicines Association did pull the marketing license for Adakveo from Novartis. And so I have heard in the background that there might be decreased production by Novartis themselves. So I definitely agree with exactly what you said of reaching out to the company to ask more. But, you know, companies often want to protect their bottom line. And so I hope that they're not going to decrease the availability of it in the United States, but I think it's possible.
Okay, thank you. And so we're going to take one question virtually. And this question says, RBCX, does the hemoglobin level affect whether or not you can get a RBCX if the patient has many vaso-occlusive crises?
So I think I understood the question, and please correct me if I'm wrong, was about the level of hemoglobin S and whether they can receive an RBCX.
Yes. Yes.
Okay, so basically how, automated red blood cell exchange, or RBCX, there's a calculation. And whether you're utilizing our device or another apheresis machine, the physician is determining, how often the patient's coming. Basically, as the hemoglobin S levels rise, you tend to have an increased risk of complications. So they're trying to keep the hemoglobin S levels low. Often, many practitioners are targeting less than 30. So I would say in that instance, it's basically your provider's preference. Some are strictly on the numbers. So they're going, if you're above 30, they're going to want to do the exchange. Some will have a different set. It's really your provider's preference, how, and then how your disease is going, any other complications, basically, are there other things they're needing to keep under control. So if a provider wants to do an exchange, they absolutely can. It's just really, how frequently is their discretion, and how frequently can you get to the healthcare center, and how frequently can you actually get it scheduled. And I know parts of the US, those two are the more challenging things for patients.
Thank you.
Okay. Thank you so much for that. All right, so we are going to be heading into emerging therapies, which is next. So virtual people, what you are going to do is you are going to leave this session and you're going to go into your schedule and you're going to go and click emerging therapies, and it will bring up a new Zoom room, and we will be getting started shortly with emerging therapies.
Before we do, Dominique, this has been a great session, but we want to give final words to Dr. Wanda Sherney and Kevin Wake.
Well, that's a surprise. Okay, well, I guess I will just start by saying, I think this has been a fantastic session. I think that, learning about the medications is so important, and everybody emphasized how important it was to learn here, but then talk to your individual doctor. I think that's really key. And I think one of the things you should talk to your doctors about too is multimodal therapy, because for a long time, like I mentioned, all we had was blood transfusions and pain medication. Then we had hydroxyurea, and that was the only medication for 20 years. And now we have 4 medications and some upcoming medications. And, when you have cancer, you don't always just get one medication. So it may also be appropriate to have more than one. So once again, great session. And Kevin, want to add to that?
You know, I just want to echo everything you just said.
Okay.
I think there's so many options out there now that it's up to the community to figure out what is going to work best for them. And even when you do find a therapy that works, you may have to tweak that and do something different. I personally get exchange transfusions was every 6 weeks, but because of not my numbers, but my symptoms, I now get it every 4 weeks because I was starting to have more crisis during that window that last week.
Right.
So there are some tweaks that have to be done. So it's not a perfect science, but I think it's up to us as warriors to really make sure that we're out there asking the right questions and utilizing what works best for us.
Yeah, and I think that also emphasizes the point that you need to talk to your doctor about any problems that you think you're having from the medication, because it may not even be from the medication. And some people have a problem and then just stop the medication and they don't even tell me that they stopped it, you know? So always stop, you know, always talk to the doctor and discuss what you think might be a complication from medication. All medications have side effects, you know? If you read the package insert to an aspirin, you probably would just keep that toothache. You wouldn't take it because you'd be afraid you're gonna die. So, okay, it's break time.